Hi, everyone. I'm going to go ahead and get started. I'm Donna Session. I'm a reproductive endocrinologist and infertility specialist at the Wilmington Fertility Center in Wilmington, North Carolina, and we are part of the Boston IVF program. And we're relatively newly opened, if you're not familiar with the program, and we are the only IVF center in Wilmington, North Carolina that has their own embryology lab and procedure room on site. I'm pleased to be able to get a chance to speak this evening, especially since it's National Infertility Awareness Week. Tonight, I'm going to speak about preconception counseling. So when a patient decides that they want to pursue pregnancy, this is a great opportunity to talk to the clinician about how we can improve health and with the goal of achieving a healthy live birth. That's what we're really striving for. So patients can see their clinician and talk about updating screenings such as pap smears and mammograms if they're indicated. It's also an opportunity to look at chronic illnesses such as diabetes and high blood pressure, thyroid disorders to achieve optimal control before pregnancy. For example, American College of OBGYN recommends that an A1C be under 6.5 in patients with diabetes. There are medications that are considered safer in pregnancy, so that might be something that one consider optimizing for certain. With patients with high blood pressure, there are medications that are contraindicated in pregnancy, such as the ACE and ARBs that can affect the baby's kidneys. And for thyroid disorders, the goal for low thyroid is to keep the TSH under 2.5 in the beginning of pregnancy, and later in the pregnancy, you can get up to 3. This is also a time to update immunization. So some immunizations such as rubella, German measles, and chickenpox of varicella are live viruses, and they cannot be administered in pregnancy. In addition, it's recommended to wait 30 days after getting vaccinated to attempt pregnancy. The flu shot, as long as it's the injection and not the nasal spray, and other ones that aren't live viruses can be administered in pregnancy. Folate is a supplement that's recommended to reduce the risk of birth defects. So typically that's in a prenatal vitamin, and the recommended doses is 400 micrograms. However, there are situations when someone would want to be on higher doses of folate, mainly if there was a history of a neural tube defect in the patient's family or a child or themselves. And neural tube defects are abnormalities in the spine and brain. And in those cases, the recommendation would be on a higher dose of folate, such as 4 milligrams rather than the 400 micrograms. Other cases might be a patient with a seizure disorder, epilepsy, then those patients are on higher doses of folate. And there are other conditions such as patients that have a disorder that affects the metabolism of folate or on medications that affect folate. Diabetes is another situation when it's recommended to be on a higher folate doses to reduce the risk of birth defects in pregnancy. This is also an opportunity to talk about genetic counseling. It was a relatively recent change, I think in 2017, when our National Society expanded genetic screening recommendations. So in the past, it was just for cystic fibrosis testing or based on ethnicity, but they increased that to spinal muscular atrophy and screening for anemias such as the thalassemias and sickle cell in everyone. There's also Fragile X is indicated in patients who have low numbers of eggs, a family history of developmental delays, usually in boys and their brothers or cousins, and history of early menopause in family members. The tests can be done with a universal screen. That those tests, you can choose how many the expanded screen includes. For example, the one that we currently use at Wilmington Fertility Center looks for about 400 genetic disorders. And they include the ones that our National Society would like to screen for, in addition to many other. These are disorders that would be serious in a child. So they're not disorders that are going to determine what your risks of, say, cancers are, or Alzheimer's later in life. They're really things that would be lethal or very serious in a child. And then you can, have both partners get tested, or look at your donor if you're using a donor and compare your testing and donor. Most of those disorders are going to be what's called autosomal recessive, where you both have to carry it, like cystic fibrosis. If both have cystic fibrosis, then 1 out of 4 children would be at risk. And there's a lot of options for people who carry these disorders. So you can test in pregnancy, you can do IVF and test before pregnancy. Someone might choose a donor or a different donor, but there are several options if we find that people carry the same disorder. And it is recommended that if you find out that you carry a disorder, that you let family members know that are also considering pregnancy. So if you have brothers, sisters, cousins, it would be helpful for them to know if you carry a genetic disorder, because they would be at increased risk for carrying a same genetic disorder. And these are not disorders that we would think would affect your health insurance or life insurance, because they're not mainly affecting you. But we can't guarantee that or always control what insurance companies are going to decide. The universal screens are usually less expensive. So if you do, the 4 tests or 1 test, they can sometimes get pretty pricey, but majority of the time with the universal screens, they try to keep the out-of-pocket expenses fairly low. Other things that can be considered are lifestyle changes, having a healthy diet, such as the Mediterranean diet has been shown to be one of the better diets to consider. Obtaining ideal body weight, a BMI of 19 to 25, exercise, and avoiding use of tobacco, alcohol, and medications and caffeine all contribute to a higher chance of having a healthy live birth. So this is not comprehensive. I didn't include everything that we talked to people about for counseling, but I thought this would at least open the dialogue for some questions. And if you have questions that aren't related to preconception, I'm open to answering things about infertility and IVF and fertility medications. So one of them just said, can you please explain the initial consult? So usually what we do at the initial consult is to evaluate those preconceptual screening topics that I did just discuss. We review the what testing has been done up to date, and see if there's anything else that we would want to complete. And then we make a plan for what are going to be the next steps. Sometimes it is, directly into treatment if the workup evaluation has been complete. Otherwise, if it's not complete, we'll complete the evaluation and then we'll regroup after it's done and come up with a plan. But, ultimately, the patient's in control. And I just give information to let you know, what are the best options for you, but you're the ones making the decision about what direction that you want to go. Okay, this question says, when is it recommended to prescribe metformin or another medication for polycystic ovary syndrome? I have PCOS, an insulin level of 9.8, blood sugars 87, hard to lose weight and keep weight down. And that makes her nervous for pregnancy. And are there any risks posed when starting it during pregnancy? So there are a number of things that we know that metformin is beneficial for. For example, if someone's going to do IVF, we know for sure that metformin lowers the risk of the ovarian hyperstimulation syndrome. The other things that we do know is that it can induce ovulation in someone who is otherwise doesn't have a period every month and doesn't release an egg. It is not as good as taking, say, letrozole, which is off-label, or clomiphene citrate. So, you might have, pregnancy rates of 22% for clomiphene versus 7% for metformin. And it takes a while for the metformin to kick in. And so you usually don't start seeing the effects of metformin maybe for 2 to 3 months. And if people aren't having periods, it's a little bit hard to tell when you start releasing eggs. That's one of the situations where I'll use temperature charting, which I don't use it very often. But if someone does ovulate and their temperature will go up, and if it stays up more than two weeks, then likely that the patient's pregnant. We do know that when you add metformin to the pills, such as clomiphene, that it does increase the chance that you're going to respond to it. So we call that clomiphene resistance, when people don't respond to those medication, and it does increase that chance. And it does increase the chance that people become pregnant on clomiphene and probably likely letrozole. And the problem with some of those studies is that it hasn't shown to increase the chance of a live birth. The problem with many of those studies is they probably weren't studies that had a high enough numbers of patients to prove that it increased the chances of live birth. But one would speculate, if it does increase your chance that you release an egg and it increases your chance of getting pregnant, it's probably going to increase your chance of having a live birth. There was one study that showed that if people had high insulin levels, that they were more likely to have a live birth if they were on metformin. There's also some controversial data about whether metformin lowers the chance of miscarriages and maybe lowers the chance of early births. We're not sure how that mechanism works. Is it, that insulin affects early births and miscarriage through its effect on progesterone, or is there something causing inflammation in that and it's affecting the inflammation? But those are all the ways that we use metformin. The risks with metformin, as we always check your creatinine to check the kidney function. And so only in patients who have impaired kidney function are at risk with taking metformin. Long-term, there was a study that said if people took it long-term, they could end up with vitamin B12 deficiency. So usually with PCOS, we're checking, blood sugar, and we're checking cholesterol every 2 years. And if someone decides to stay on metformin long-term, we just throw in a B12 vitamin with those tests. Okay, what's the difference between IVF and IUI? So IUI is intrauterine insemination. So IUI is fairly simple. So IUI is where we take a sperm sample. It can be from a sperm donor, or it can be from a male partner. Those samples are washed. And the reason why is if they're not washed, it'd be very painful or crampy. And probably would affect chance of pregnancy. And it takes about an hour or so to wash the sperm. And then we put it in a small soft plastic catheter, and it's kind of similar to doing a pap smear. There's a speculum, and we pass the sperm into the uterus with the catheter. So inseminations are quick. Takes probably 10 minutes to do insemination. There's no restrictions on your activity. It's flexible as far as when you can do this, so it doesn't really affect your work life very much. So our National Society SRM says that we can do an insemination anywhere from 0 to 36 hours after ovulation, and we usually control that with a trigger shot, and so that you have control over when that happens. There, there are a number of times when we, recommend doing insemination. So it could be because of factors on a semen analysis. The sperm might be in the fluid might be viscous, and we put it into water and help them swim. It may be that the sperm count is borderline low. And so we know that if there's a borderline sperm count, that we're going to increase chance of pregnancy with an insemination. We often do inseminations along with fertility medications. In patients with unexplained infertility, our National Society recommends doing a combination of fertility medications such as clomiphene, the oral agents, plus an insemination, because we know that's what's going to statistically increase chance of pregnancy, is a combination of the fertility medications plus the insemination. And that's recommended to do 4 cycles before going on to IVF in women under 38. If women are over 38, that you may want to go towards IVF quicker. So on average, the chance of pregnancy with an insemination is about 5%. If we add in some fertility drugs, it may be 10%. But on average, if you look at ages with IVF, that's about a 50% chance of pregnancy. And IVF is where we collect the eggs, we fertilize them in the laboratory, and then we transfer an embryo back into the uterus. So an IVF has a higher chance of pregnancy because there's lots of things that we can do with IVF that's going to improve chance of pregnancy. So for example, we can make sure fertilization happens by injecting a sperm into an egg. We can hatch embryos if we feel we need to hatch them. So human embryos do have a shell around them, and they need to hatch to attach to the uterus. And sometimes on the day of the embryo transfer, where we put the embryo in the uterus, the embryologist might note that that embryo is not hatching. And there's many ways that you can hatch an embryo. You can do it just mechanically, crack the shell. We used to do it with acid. Nowadays, it's done with laser just because it's quick and we think it's fairly safe. But the difference in chance of pregnancy hasn't really changed. IVF also bypasses the tubes and the ovaries, and there may be something there that we can't see with our screening tests that might be causing people not to get pregnant. There might be what's called endometriosis, where that's where the lining of the inside lining of the uterus is outside where it shouldn't be, and it's inflammatory and toxic for gametes, and we're bypassing those things. So IVF, there's a lot of reasons why it has a higher chance of pregnancy than insemination. And but it's a little bit time consuming. So with IVF, you're talking about a 2-week time commitment where you may be getting ultrasounds, every other day in the early morning with blood work. On average, it takes about 10 days for the eggs to grow. It's a lot of injections. And then on average, usually on day 12, we're going to collect the eggs. And when we collect the eggs, it's under anesthesia. So that does affect time off from work for not going to work for 24 hours because of the anesthesia. Although collecting the eggs is fairly quick, usually 10, 20 minutes. It's a needle about the size of an IV that goes through the vagina, attaches to the ultrasound. You just, 1 needle stick per ovary, so it's fairly low risk. The reason why we have people asleep is where the eggs are in the ovaries really tense like a balloon. So if I touch the ovary with the needle and someone flinched, we don't get the egg, and we want to get every egg we possibly can get with IVF. And then if people go forward with a fresh embryo transfer, which is the current recommendations from our National Society, if we consider it safe, then usually 5 days later, we place an embryo into the uterus. And that is usually midday, and we use Valium prior to that procedure. So to relax the uterus and to decrease the chance of that an embryo being expelled into the vagina, although there's not very good data for that, but that it does mean another day off work for the embryo transfer. So it is a little bit time consuming, but it does have a higher chance of pregnancy. There are people who where IVF is going to be indicated rather than IUI. For example, if the tubes are blocked, then IVF is going to be the main option. If the sperm count's very low, under 5 million, then IVF is going to be the main option for those patients. Okay, so this one says, I recently had a miscarriage, and will this affect my chances of conception once I start trying again. So actually, if someone's gotten pregnant, then it makes it more likely that someone will get pregnant again. So it is actually a favorable prognostic sign. And so it just means everything's working. And so, and in the past, we used to recommend that people wait and take a break after a miscarriage for 2 to 3 months. But now the recent information is that it's better not to delay. And the sooner people try to get pregnant again, the higher the chance of pregnancy. I mean, if there have been multiple miscarriages, then we're going to do a workup to try to find out why someone's miscarrying. And there is some evidence in that in someone who's had a miscarriage before, that once someone has a positive pregnancy test or after you ovulate, to consider taking a baby aspirin if you're not allergic and can take it of 81 milligrams once a day to lower the chance of having another miscarriage. Okay, I have 2 boys and will want to try for a girl. Is it possible to select the baby's sex? So one can through IVF. And so this is something that can be done with our program with Boston IVF, but it does require someone to go through IVF. Then we collect the eggs and we have to fertilize the eggs and create an embryo. And then when it's about 5 days, sometimes we go to day 6, day 7, we take a biopsy of the cells that would become the placenta. And then we send those off to genetics to look for male or female. In general, they're going to screen for all the chromosome numbers. So those tests will screen out things like Down syndrome and common causes of miscarriage. I mean, it doesn't eliminate the risk of miscarriage or Down syndrome. These tests are fairly accurate. You're talking about 95+% accurate. It's not, these tests aren't 100% accurate for male or female. It's probably higher than for screening for Down syndrome, but they aren't 100% accurate. Sometimes we don't get any results, and sometimes we get all boys and all girls. It all depends on how many eggs people have to start with, what the likelihood of success that we'll find a male or a female embryo, a genetically normal embryo. So this one is, what do embryologists study to become an embryologist? And so there are, usually it's a patient who's had, training and courses in biology. And there are programs that have specialized courses for an embryologist. Usually they're about a year long. And this is something that's a little bit outside my area. I think Boston IVF might have some training for embryologists. And there's other IVF centers that I've heard of that will provide those courses. Let's see. All right, this one is a patient who's 39 years old, husband 42, did insemination in Raleigh and lives closer to Wilmington. Do you prioritize IVF, or would I need to continue IUI tries? So, this is really up to the individual, whether or not they, want to try inseminations versus want to try IVF. And so it's a personal decision. If someone does IUI, most of the time people are going to get pregnant within the first 3 tries, because if it's going to work and fix the problem, it's probably going to fix the problem in 3 tries. But we still can go up to 6 inseminations, and I still see pregnancies up to 6 inseminations. If not in 6, then probably not likely that that's going to work. And then if IUIs aren't going to work, then to go on to IVF. And so, but it's an individual decision. Sometimes people make that decision based on what their ovarian reserve testing looks like. So if someone has a lot of eggs, then they have more time and then can try insemination before going to IVF. If someone is, has borderline number of eggs, or and so it declines faster after age 38, they might want to do IVF sooner rather than do insemination. So, for example, I've had patients who've had few eggs, so they opted, well, I'm going to do IVF first, because then if I'm not pregnant with IVF, I can always go back to doing IUIs. There is some evidence in women over 40, if you have 4 or fewer eggs, then you're better off doing inseminations, because with IVF, it's all about the number of eggs. And so the more eggs we get, the higher chance of pregnancy you're going to have with IVF, because we don't collect all of the eggs. We collect about 80% at the time that we do the egg collection. About 70% fertilize, 50% will grow to day 5. And these are all averages, and about 50% are going to be genetically abnormal. And so the chance of IVF success is going to be, with higher numbers of eggs. And so it may not be the best option for someone. So it's really, a personal choice, what someone wants to do. And you're very welcome that we're doing this tonight. Thank you for that. Let's see. Do you have to wait to start a frozen embryo transfer after starting your menses, even if you have PCOS or very long cycles? Can you start before, as long as you get testing to confirm you aren't ovulating? Metformin hasn't regulated my cycle yet. So normally we are going to, let's see. Okay, normally we are going to induce a menses before someone starts a cycle, such as a frozen embryo transfer, just because if in the past that the lining has been exposed to any progesterone, such as like Provera or Prometrium or birth control pills, then that lining changes. And so what we have to do is we have to sync the embryo with the lining of the uterus. And the progesterone is really important. That goes back to like an old study where they showed if you were out of sync, it was 0% chance of pregnancy, versus if you in sync, it was a 50% chance of pregnancy. So the important thing is to make sure we're starting with a baseline of a lining that's been shed and that hasn't been exposed to progestins. And that can be any form, as I mentioned, Prometrium, or which is the brand name, or Provera is another brand name, or birth control pills. And there are different ways to, to shed the lining. Sometimes people have a very thin lining and there's nothing there to shed. And we can induce a menses with hormones, or there's different ways and tricks to get people to shed a lining if it's thick. Can a couple do gender selection during sperm washing? That I haven't really seen that to be very successful. There were some programs that were doing staining of the sperm to identify male versus female. I think they were binding the DNA. I don't know how safe that is to do dyes that bind the DNA and what the long-term safety was on those studies. But I think since we can do it fairly well with fairly high accuracy with IVF, I haven't seen people doing the sperm washing looking for males. And it wasn't, even when it was being done, I don't think that it was highly effective at selecting male versus female. All right, this one is, can I do IVF if I have a low egg count? So again, it's really, your choice whether you want to do IVF. The fewer the eggs, the lower the chance of success IVF will have. Largely that's dependent on age. And so if someone's older, they'll have a lower success rate than someone who's younger. Typically in someone who's like under 35, if we can get an embryo, then their chance of pregnancy is not a whole lot different than someone who has a large number of eggs. And so, I think it depends on, if we look at the number of eggs, if there's only 1 or 2 eggs on ultrasound, then it's not very likely that I'm going to end up with an embryo, because 80% chance I get an egg, 70% chance it fertilizes, 50% chance it grows, and 50% chance it's abnormal. And so if I'm starting off with 1 or 2 eggs, then the odds of me getting an embryo that's genetically normal is fairly unlikely. But I don't have any arbitrary cutoffs. And so if someone wants to do this, I've had people do IVF with one patient only had 2 eggs, and she conceived. And so it's an individual choice, and you just need to know going into it what the success is, and be realistic about how likely this is to work based on the number of eggs you had. I know there are programs that will have arbitrary cutoffs. They might say, well, you have to go to have 5 eggs to have the egg collection. But, in those programs, they're really doing that because, all of our statistics are sent to the CDC by law, and people can compare programs. And so there are programs that want to make their statistics look better. And so for me, there's no arbitrary cutoff. It's just an individual decision whether you want to go forward or not. And it does impact costs in a lot of places. So a lot of the cost is in the egg collection and the anesthesia and identifying, the oocytes and fertilization. So some people might look at it as a cost. And so if I'm only making 1 or 2 eggs, if the tubes are open and the sperm, count is good, then maybe I'll do an insemination this cycle and not collect the eggs and go forward with IVF. And I've had patients make that decision, on a month by month basis. And so, 1 month, you only have 2 eggs, and we'll say, okay, we're going to do an insemination this month. But the next month they might have 5, and they say, well, we're going to try to do the IVF this month. So it can be a month to month decision process. And the number of eggs that people are making started 3 to 6 months ago. So we don't really have control over how many eggs someone is making. This is really something that people don't understand. But we do know if people have fewer eggs in the ovaries, that they make fewer eggs. So someone who has 500,000 eggs in the ovaries usually makes about 20 eggs a month, and someone close to menopause makes 1 egg a month. And there still are about 1,000 eggs in the ovaries close to menopause, but they're only making 1 egg, and that started so long ago, and we didn't have any control over it at that time. Okay, this one is what medications are taken after multiple pregnancy loss to prevent another loss? Well, if someone's had multiple pregnancy losses, there's a lot of tests that we do to evaluate it. And then those tests decide, what are the best treatment options. And so typically if someone's had 2 miscarriages in a row or 3 total miscarriages, then we're going to do an evaluation of why the miscarriages are happening. And there are 3 known reasons to miscarry. One is the abnormal shape of the uterus. That's a heart shape. Usually you can see that on ultrasound or X-ray or MRI. And that's relatively simple to treat because it's an outpatient surgery that goes, through the vagina just to correct the shape of the uterus. There are genetic disorders. So when it's one piece of chromosome is misplaced with another piece of chromosome, it's called the translocation. And for patients with a translocation, the recommendation is to do IVF, and you can test for that translocation prior to pregnancy, or some people will opt for donor egg or donor sperm based on who has the translocation. Then there's the blood clotting disorders. Those are like the antiphospholipid antibody syndrome. Those tests which cause clotting, the idea is that when the placenta is trying to attach to the uterus, that your body clots off the placenta and then you miscarry. And so in those cases where people have a clotting disorder, it's a combination of the baby aspirin, which is 81 milligrams by mouth once a day, and an injection of a blood thinner. And we can go from a 40% chance of live birth to about an 80% chance of live birth with those 2 in combination, but they were always in combination not alone for patients with a known blood clotting disorder. There's other things that we look at, even though there's less data to support them. So we'll look at thyroid antibodies, the thyroid disorders, and our National Society says if people have thyroid antibodies, it's recommended to treat that with thyroid medication to lower the chance of miscarriage. We look at other hormonal things like diabetes and prolactin, although they have less evidence. The other thing we look at with people with miscarriage is the inflammation of the lining of the uterus. And so, they think up to like 56% of women with miscarriage can have inflammation of the lining of the uterus, and that's due to bacteria. And so there's a much greater emphasis on this recently, as far as the good bacteria and the bad bacteria in the uterus. And so if there's the good bacteria is like the lactobacillus, so that's what's in your probiotics and your yogurts that have the live bacteria in it, and that keeps the bad bacteria out. And the bad bacteria, one of the most common is strep, and or there's E. coli, and there's Enterococcus is a common one, ureaplasma, mycoplasma. So there are a number of bacteria that have been shown to lower chance of pregnancy and increase chance of miscarriage. And what we know is if we just gave antibiotics, the chance of someone with multiple miscarriages having a live birth is about, I think the study was 56%. But if I can clear the infection, the endometritis, then the inflammation, the lining of the uterus, we can get to about an 88% chance of live birth if that's the cause of the miscarriages. There's also a test, that's commercially available. It's called Alice and Emma. And I've used that, and I think that's commonly used in Boston. It's a different type of test. They do PCR for bacteria in the lining of the uterus. So either way, we have to take a biopsy of the tissue of the lining of the uterus, because the bacteria in the uterus are not the same as the bacteria in the vagina. And I usually send it off for histology for inflammation and do a culture, because I can get sensitivities and find out what antibiotics to give to help clear the infection. The Alice and Emma is a PCR test where they amplify the bacteria in the uterus. And then what they do is, if they find it, they can't do cultures and tell you what it's sensitive to, but they can tell you, so if it's strep, it's most likely going to be sensitive to a penicillin. So you can get an idea of what would be the best antibiotic to clear that. Other things that have been associated with miscarriage is diminished ovarian reserve, or having fewer eggs. But, it's not a very high chance of miscarriage that's associated with low number of eggs. It might be, we did a study and it might be like 12% instead of 10%. There have been studies in the past with IVF that people have fewer eggs, that they might have a higher risk of miscarriage because of, extra chromosomes like Down syndrome, and that's extra chromosome 21. But the common causes of miscarriage are like extra chromosome 16 or 18. And that is the most common reason that someone miscarries, is that it's going to be genetically abnormal. So it never was going to be a viable pregnancy. So if you have an extra chromosome 16 or 13, you're most likely going to miscarry that, because it's not a viable pregnancy. One can test, with IVF and doing PGT, pre-implantation genetic testing, and screen for the common causes of miscarriages, like the extra chromosomes 16 and 13, although it doesn't eliminate the chance of miscarriage. So one of the recent studies says by doing PGT, the miscarriages decrease from about 12% to about 8%, but that's the most common reason for people to miscarry. Boston IVF, I think, just had a study published in September of last year that got a lot of attention, because they looked at patients who had few eggs, and they didn't see any increased risk of, abnormalities that would cause miscarriage. But if about 50% of the time we don't find any reason for people to be having the miscarriages, we're usually going to use the baby aspirin, 81 milligrams by mouth once a day. And you can get those over the counter. The ones that are the heart healthy ones that are coated are a little bit easier on the stomach. And then we also use progesterone, because we don't really have a way of measuring whether someone's progesterone is too low. And so we just give everybody progesterone. So, you can do 200 milligrams of progesterone twice a day. Statistically, it wasn't different 3 times a day, although it was slightly better outcome 3 times a day. But I found that a lot of the insurance won't cover 3 times a day because it wasn't statistically significant. So most of my patients are taking their progesterone twice a day. Both the baby aspirin and progesterone can act a little bit like a birth control. If you take it too early in your cycle before you ovulate, it can prevent pregnancy. So they can be taken, if you do an ovulation predictor kit, you can start them 3 days after ovulation, or some people who've had later miscarriages opt to start it with a positive pregnancy test. So this is twins run in my family, but I only want to have 1 child at a time. Is it possible to make sure I don't have twins? I think the only way, really to reduce that chance is to do IVF and place 1 embryo into the uterus. But having said that, it's still not 0. And so, the chance of us having twins with transferring 1 day 5, like 5-day-old embryo blastocyst is still around 2%. It's lower with a day 3 embryo. So if you transfer an embryo on day 3, your chance of identical twinning is about the same as occurs naturally, about 1 in 200. So I think if it's identical twinning, then it's probably not going to be any different than IVF. A lot of people do release more than 1 egg a month. People are surprised that that happens. It typically happens more in people who are older because that FSH hormone starts going up, and that's the hormone that increases the number of eggs that grow. So usually it's women who are older, over 35, end up having more twins than younger people that are not identical. All right, is there a way to lower FSH? There are things that we can do to lower FSH. So, the feedback for FSH is estrogen. And so sometimes we give estrogen to people during the second phase of their cycle after people ovulate to lower the FSH. But lowering the FSH is not going to increase the number of eggs that people are making. And it's not going to increase someone's prognosis. So the chance of doing well with IVF depends on the FSH because it depends on number of eggs. And it depends on whatever the highest FSH was. So if you had a high FSH, but then went on something and then rechecked it, and then it was lower, your prognosis is always whatever the highest FSH was. And just because it's just an indicator that you have fewer eggs, and then IVF is all about the number of eggs you have as far as how successful it's likely to be. When we use estrogen to lower it, usually those are the situations where we give estrogen in that later part of the cycle to lower the FSH, so that we can sort of slow things down a little bit. And we'll do that in patients who have high FSH, and then they end up with a lot of cysts that get frustrating to do the cycles in. And so, we call it luteal priming. So it kind of slows down that FSH and then synchronizes the eggs so that people can have a better cycle. But inhibin is the main feedback to lower the FSH. And as the ovaries age, there's less inhibin. So we do not have good control of the FSH because we cannot give people inhibin. All right, this one, I was diagnosed with endometriosis. Will I still be able to have children? So endometriosis is when that inside lining of the uterus is outside of the uterus where it shouldn't be. And we don't know why people get endometriosis. Part is the theory is that the blood is going back through the tubes at the time of people's periods, but that happens in almost everybody. And so why in some people it sticks and grows and other people it doesn't, we're not sure. Endometriosis is associated with a lower chance of pregnancy because it causes inflammation and seems to be toxic for eggs and sperm, but it doesn't mean people can't get pregnant. Usually what I do is use, if someone wants to try something like a fertility drug or do inseminations, I usually use the drug letrozole because estrogen is what stimulates the endometriosis to grow, and letrozole actually blocks production of estrogen. So I think that's probably your best option for not worsening endometriosis, which what a lot of the other fertility medications can do. Endometriosis is associated with people having fewer eggs. We're not sure why. Did having fewer eggs result in getting endometriosis, or well, we do know people who have had a lot of surgeries on their ovaries end up with fewer eggs, and so that can contribute to it. But for sure with IVF, people with endometriosis end up having fewer eggs, but it doesn't mean that it can't be successful. It may be someone might want to do it sooner rather than later, depending on what their egg count is. It's certainly recommended that people sort of optimize their fertility with endometriosis. And there is some evidence that medications such as birth control pills can lower progression of endometriosis, or blocking the estrogen reduction with medications similar to letrozole. Those would be sort of off-label, but endometriosis can make its own estrogen, and so it's sort of self-promoting. And so you can block estrogen production from the ovaries and with birth control pills, but if you add on something like letrozole, then you might be blocking the estrogen production in the endometriosis itself. And there's also medications that block your FSH production and LH from the pituitary, and those medications can decrease recurrence. I think they're usually used, for pain. If birth control pills aren't controlling the pain, those are options. But generally, you want to be on something that's going to decrease the chance of it worsening, because endometriosis can cause scarring, it can block tubes, and so you want to catch it early and try to prevent those things from happening, prevent the loss of the open tubes and things like that. All right, so this says 2 failed IVF cycles at another clinic, 39 years old, miscarried at 17 weeks, all looked fine with an embryo. I was told was good. Overall, my confidence in my current care is very low, and I don't want to experience this again. I guess my question here is, how can this happen? And what can I do to maximize my chances? I'm not sure how to handle another loss like this with no answers. I'm not sure where to turn locally. Thank you. So I'm so sorry. I mean, that's a really late loss. I'm sure that was just devastating to go through. I think when the losses are that late, usually it's a combination of both someone like me plus someone in high risk that evaluates why that loss occurs. So typically it's both of us that are looking for things that are the cause, and trying to do everything we can to prevent it from happening again. I don't know that we can prevent every miscarriage from happening again, but we certainly can look for all of the possible etiologies for the miscarriages, like we talked before. When losses occur later, usually they're looking at the genetics of the pregnancy. We do also do the test for the inflammation, and typically if there's a loss that late, we're also looking at other causes of blood clotting. And so I mentioned before, we do the antiphospholipid antibody syndrome, the APAS. But if someone's had a later loss, we usually look into other blood clotting problems, such as factor V Leiden and antithrombin and prothrombin gene. And so there's a much larger screen that we do with people who are having late losses. And those, if we do find a blood clotting disorder as a cause of that, then it is a combination of the baby aspirin and like heparin, both in combination. try to decrease the chance that there would be another loss. So there are things to look at, and so but it depends on what testing's been done up to now, and then and what we could do to try to lower that risk in the future. Oh, this one is this is, I think, the last question. Are we doing IVF now? So we are doing IVF at in Wilmington right now. So the program is open, and so we can freeze eggs, we can do IVF, we can do embryo transfers, we can do frozen embryo cycles. What we're getting close to, I think, doing is donor egg from donor egg banks. I think a little further off will be gestational carrier. There's just a lot more to do to prepare to have gestational carriers. But for most of the IVF, we're up and running. We can do PGT and most of the micromanipulation and techniques and things in the laboratory are available for people. So I think that was the last question, maybe. Yeah. So I'd like to thank everybody for being here tonight. And it was a pleasure to answer these questions. And I hope everyone has a great evening.